Okay, now we're going to discuss the topic of pneumonia. Okay, please excuse me.
Peter, kasama ka? Oo, sige.
Okay.
O, ipapasok mo. Sabi mo pag 12:30 na, ay pag 11:30, labas na yung...
Okay, everyone. Please excuse the please excuse the sandali lang, sandali. Okay. Please excuse the interruption earlier. We'll now resume our topic with pneumonia. Okay. Okay. Okay, so now we're going to discuss pneumonia. So there are different things that can cause pneumonia. You have community-acquired pneumonia, you have atypical pneumonias, and you have nosocomial pneumonia, aspiration pneumonia. You have nosocomial pneumonia, aspiration pneumonia, lung abscess pneumonia, chronic pneumonias, pneumonia in the immunocompromised host, and pulmonary disease in human immunodeficiency virus infection. We will also be tackling COVID pneumonia, of course, in this topic. So you have basic considerations, pneumonia versus pneumonitis, of course. And then you have differentiation from injuries, obstructive diseases, restrictive diseases, vascular diseases, differentiation from neoplasms, classical stages of inflammation, lobar pneumonia versus bronchopneumonia, interstitial versus alveolar, community versus nosocomial, and etiologic agents versus host immunity. And then, of course, you have presenting symptoms and diagnostic methods. So this is quite a big topic. You should know that any organism can cause pneumonia. That's the first thing. Any organism can cause pneumonia, whether this is bacteria, this is viral, or fungal. Anything can cause pneumonia. So there are predisposing factors that may make you more prone to get pneumonia. First, you have the loss of the cough reflex, diminished mucin or cilia function in your respiratory system, alveolar macrophage interference, vascular flow impairments, and bronchial flow impairments. Although pneumonia is one of the most common causes of death, it usually does not occur in previously healthy people or in healthy people spontaneously. So let's go to the different classifications of pneumonias. I'm going to just flash them here on the screen. Let's go and discuss community-acquired pneumonia. Community-acquired pneumonia, one of the most common bacteria that can cause this is Streptococcus pneumoniae. And this is a Diplococcus microorganism. So this is one of the most common other microorganisms that can cause community-acquired pneumonia is H. flu, Moxarella, Staphylococcus or staph pneumonia, Klebsiella pneumonia, Pseudomonas aeruginosa, and Legionella pneumophilia. Although Pseudomonas is commonly seen in also nosocomial pneumonia. Let me point that out. Also, Klebsiella is commonly seen also in hospital-acquired or nosocomial pneumonias. So Streptococcus is the classic lobar pneumonia. Streptococcus is found in the normal flora of 20% of the adults, and only 20% of victims will have positive blood cultures. Penicillin is often 100% curative, and vaccines are often 100% preventive. Although I do have to point out, because of problems with the bacteria, they become more resistant to the antibiotics. Resistance or microbial resistance have been growing in the past years. So although penicillins are often 100% curative, now with the advent of culture and sensitivity, we are able to pinpoint which bacteria will be resistant to certain medications. And of course, because we want to be vigilant with the use of antibiotics, we want to decrease antimicrobial resistance, which we have been observing in the past years. Usually, any antibiotic is usually given a minimum of 7 days. And we want to avoid, some people are cutting it short, when they get their microbial treatment. When they feel better after 3 days, they stop taking it, when actually you should encourage that they take it for 7 days. With the exception of a macrolide drug like azithromycin, that can be taken for a minimum of 3 days. Actually, 3 to 5 days, it can be given. Because we have found out that macrolides like azithromycin, their oral preparation and IV preparation has the same amount of tissue penetration, and that it is long term. It lasts for several days. So which is why with azithromycin, it can be given for 3 days for there to be treatment to occur. So anyway, going back to streptococcus, penicillins are often 100% curative, and so is the vaccine can prevent streptococcus pneumonia. So this is an example of lobar pneumonia that you can see on the screen, on the X-ray. So you can see this has affected the right lobe, the right upper lobe, and portion of the middle lobe. Okay, so you can see definitely the right upper lobe has been affected here. And then here you can also see grossly that there has been a problem with, when you look at the lung grossly, that you can see there has been a problem with the lungs here. And then microscopically, of course, you can see streptococcus. These are diplococci. You can see that. It comes in pairs. See that? Okay. Okay. Let's go to Haemophilus pneumonia. This is common in children less than 2 years old, and common infections that can cause that have Haemophilus Haemophilus as a cause is otitis, upper respiratory infection, meningitis, cellulitis, and osteomyelitis. So in children less than 2, they are often thought of being H flu until proven otherwise. So otitis infections, that means infections of the ear. Meningitis, which means inflammation of the meninges of the brain. They can be it can be a sequelae of Haemophilus infection. So this is the most common pneumonia in COPD in adults, and usually Bactrim is an effective treatment, or cotrimoxazole. This is a sulfa drugs. Of course, in the advent of drug resistance, we have been noticing increased resistance to sulfa drugs or cotrimoxazole in the past several years. But before, Bactrim, this is the brand name, or it was a very common treatment. So it can be referred to as cotrimoxazole or trimethoprim sulfa. So here you're looking at an X-ray of Haemophilus. So here you can see on the X-ray this area. And then here you can see the meninges of the brain being affected. And you can see how it appears on microscopically here in this photo. Lumabas lang yung... Okay, let's go to Moxarella catarrhalis. This is the second most common pneumonia in COPD patients after Haemophilus. And this is a gram-negative coccobacillus like H influenza. Staph aureus is the most common pneumonia following a viral pneumonia. So if you develop a pneumonia after a viral infection, this is the most common cause. MRSA, or methicillin-resistant Staph aureus, of course, is usually not community-acquired. Staph aureus can be community-acquired, but when you are talking about MRSA, or methicillin-resistant Staph aureus, this is not commonly community-acquired. And of course, MRSA is more difficult to treat than Staph aureus. And there are more drugs, there are limited drugs that can treat it compared to Staph aureus. There are more drugs that can treat Staph aureus compared to MRSA. Klebsiella pneumonia is very common in debilitated patients, malnourished patients, alcoholics. So alcoholics with pneumonia are often thought of having Klebsiella until proven otherwise. And let me point out that debilitated people can be people, for example, who are immune compromised also. So the diabetics are one, for example. So debilitated, malnourished people, alcoholics, are very prone to Klebsiella pneumonia. Going to Pseudomonas aeruginosa, this is usually not community acquired but nosocomial. I think I pointed that out earlier. Cystic fibrosis patients with pneumonia are presumed to have Pseudomonas until proven otherwise. Okay, so Pseudomonas aeruginosa, this is nosocomial. This can cause nosocomial pneumonia. This can cause nosocomial problems. I even pointed out also Klebsiella can be a problem, but this Pseudomonas is a very common nosocomial microorganism. So cystic fibrosis are presumed to have Pseudomonas until proven otherwise. Legionella, okay, Legionella pneumophilia. This often occurs in outbreaks and it is often lobar. So this will cause lobar pneumonias. It is spread by water droplets, very common in air conditioners. And this occurs very often in immunosuppressed patients. There was a convention in Philadelphia many years ago where there was an outbreak in the hotel, and they noticed that it was there was a convention of the French members of the French Legion. So they started calling it Legionnaire's disease because they were affected. And when they looked into the disease, it was found to be in water droplets that was from the air conditioning. So this can be treated by macrolides like erythromycin, clarithromycin, azithromycin. Okay. And immunosuppressed patients can be affected by Legionella pneumophilia, or what they call Legionnaire's disease. So that's how this got its name. So although pneumonia is one of the most common causes of death, it usually does not occur in healthy people spontaneously. So something must have affected you in order for your immune system not to have fought back as well as other people who would have been exposed. So let's look at the morphology here. Okay, I'm flashing this slide. Let's look at classifications again of pneumonia. Let's go to community acquired pneumonia causing atypical pneumonia. Okay, let's look at atypical pneumonias. They can be viral, like influenza, mycoplasmal pneumonia, mycoplasma pneumonia. Mycoplasma pneumonia is an obligate intracellular bacteria. Let me rephrase that. It is an obligate intracellular microorganism. Okay, that sounds better. It's not bacterial and cultures are not usually helpful. This is in atypical pneumonias. Okay, let's look at viral pneumonias. These are frequently interstitial and not alveolar. So this is a generalization, okay? But of course, there are exceptions. Everything has an exception every now and then, okay? So this is interstitial pneumonia, not alveolar in viral pneumonias. So let's talk about the influenza virus A, B, and C. It caused the first it caused an earlier pandemic. We are having the SARS-CoV-2 um, pandemic right now. But 100 years ago, 1915, 1918, there was a pandemic and it was caused by the influenza virus. It has mutated throughout history. There have been many strains like the avian swine. Type B and type C are commonly seen in children. And the exact strains can be identified by PCR test or polymerase chain reaction test. So I'm showing you an X-ray. And as you can see, there are infiltrates in this area. A little bit here. Now we're going to discuss the SARS. Before we had the SARS-CoV-2, which is affecting now, there was in 2002, the SARS, the first SARS, the severe acute respiratory syndrome. It was also a coronavirus. There was an outbreak in 2002 in China, and it spread chiefly in Asia. Like most non-bacterial pneumonias, it can be confirmed by PCR. And like most viral pneumonias, the interstitium was infiltrated, and some giant cells were also present when it was seen microscopically. So here is an appearance of the coronavirus, the SARS coronavirus, the first one. And as you can see, when this was identified, they saw the spike proteins. So that's it. It appeared around, so it gave the appearance of a crown. So they called it the coronavirus because of that appearance. And this is an example of what you can see on an X-ray of a SARS-CoV patient affected. Okay. So COVID-19, this is the SARS coronavirus 2. 2019, there was an outbreak in Wuhan, China. It is now causing a pandemic. And like the SARS-CoV virus 1, it is confirmed by PCR. It has a combination of respiratory symptoms. So this is a bit different with the first SARS. Right now, we are seeing a combination of respiratory symptoms, inflammatory reactions, immune compromise, and thrombosis and blood clotting in patients. So not much is known, and more are being discovered every day. And right now, doctors and scientists are still trying to come up with a regimen of treatment for this illness, because there's really no known drug that can completely treat the coronavirus 2 or prevent it absolutely, like it can be a prophylaxis. So there are still studies being looked into that. But when this coronavirus started in 2019, and then this spread in 2020, what we knew in January of 2020 was not what we knew in March, and it was not what we knew in August. So doctors we were trying everything, different regimens to see what would work on our patients. So after Wuhan, they did autopsies which would look into the diagnosing of this virus. But when it spread to Italy, Italy did a lot of autopsies, and what we know of what is happening to the patients was seen in Italy in their autopsies. And we found out there in the autopsies that they did that there were multiple blood clots that were going on in the entire body. And this was causing the anoxia also, because there is the difficulty in the delivery of oxygen to all the tissues, right? So I'm sure you can understand that because uh, if there's no oxygen delivery, then of course there will be um, not just lung failure, but failure of the entire body, failure of the organs. So not everyone on the planet will get COVID-19, but 80% of those who will get the virus will have either mild or no symptoms. Roughly 15 to 20% will have pneumonia, although these numbers may change. Okay, these numbers may change. Roughly 4% will develop ARDS or shock with multi-organ failure, and roughly 1% will die of infection. The numbers may change. Why? Because these are numbers based on the original strains of COVID-19. As mutation has been happening for this virus to survive, it has been more infective. In other words, it can be transmitted easier and faster. And of course, aside from that, it may have changes in how it will react, because so you know, we have the variants from UK, from Brazil, South Africa. We have a Philippine variant. We now have an Indian variant. So the numbers may change. Those who die of infection, those who will develop ARDS, and for example, in the Indian variant, they found 2 mutations. And lately I heard that here in the Philippines, they have found 3 mutations of the Indian variant. And what they're looking into now is that whether this Indian variant is more infectious, and they think that it is more infectious, it's easier to transmit, and if it will bypass the antibodies formed that previous COVID patients have developed and people who have received vaccines. So whether it will bypass those antibodies that have been formed from vaccines. So definitely, we should still be vigilant. We should still social distance. We should still keep the social distancing is 2 meters apart or 6 feet apart. Wear masks, wear face shield, wash our hands all the time, sanitize our hands, and avoid gatherings. And this is one of the mistakes that India made, is that they did a lockdown same as the Philippines. But then at the end of November 2020, they started being more lax, and then they had some gatherings, religious gatherings, and then they held an election where they allowed gatherings during their election. And so what you're seeing in India now, it is now the hub, the highest amounts of infection in the world. Before it was the United States, now it's India, to the point that they are now lacking oxygen, and they even have placed a ban on what you would call the exportation of medicines, the COVID medicines that we now use. A lot of our medications are being produced in India, but because they have very high cases in India, what they have stopped exporting the medications in order for them to use it. And they were not able to vaccinate a lot of their citizens. So here in the Philippines, since we have not yet vaccinated all our citizens, we have not reached herd immunity at all, we still have to be very vigilant. And see what happened to India. Learn from what happened in India. Okay, so the current medications that we're using right now to treat COVID-19 are medications like remdesivir, tocilizumab, dexamethasone. These are approved FDA medications, but under compassionate use. And recently, it has approved leronlimab. Okay, there's also approval of favipiravir. Okay, and then so hospitals, institutions are applying for the use of these medications under compassionate use. The WHO is not yet approving the use of ivermectin. So it is not recommending the use of ivermectin, but I do know that there is a lot of research going into that, if that would prove to be used prophylactically. However, the amount of ivermectin that you need to actually make a difference might be approaching toxic doses. And usually this was being given as an antiparasitic drugs for animals. Okay, so just to elaborate on that. Let me reiterate also that comorbidities will increase the risk factors of getting COVID-19. People have heart conditions, hypertension, diabetes, renal problems. They will increase the risk factor. The elderly, for example, being elderly. So pregnancy, elderly, young children, we're not allowing them to go out. People with comorbid illnesses, we're not allowing them to really go out. We want them to be very careful. Okay, so let's now go to nosocomial pneumonias. So nosocomial pneumonias are usually acquired in hospitals. It's also called hospital-acquired versus the community-acquired pneumonias. Usually, the patients who have nosocomial pneumonias will be debilitated, immunocompromised. They may have catheters, ventilators. They may have Enterobacter or Pseudomonas, of course. They may have staph infections like your MRSA or your methicillin-resistant staphylococcal infections. So other causes of nosocomial pneumonias are Pseudomonas aeruginosa, Klebsiella, E. coli, okay, your staph pneumoniae, H. influenzae. Okay, so these are things that can cause your nosocomial. So the staph pneumoniae, I'm also pointing out that this may be your MRSA, because your MRSA is also staph, but not all medications will work on methicillin-resistant staphylococcal infections. Okay. Let's now go to aspiration pneumonia. So aspiration pneumonia are very common in unconscious patients and patients in prolonged bed rest. And usually they lack the ability to swallow or they lack the gag reflex. So this causes aspiration of gastric contents, or if you were feeding them, instead of going down to the esophagus, because of the proximity of the esophagus and the trachea, it had gone down to the trachea. This is also very common in drowning patients, aspiration pneumonia. So the posterior lobes are usually affected because of the gravity. It's gravity dependent. Most commonly involved are the superior segments of the lower lobes and even the middle and lower lobe of the right lobe of the right lung. And this will often lead to abscesses. So this is an X-ray of a sample of aspiration pneumonia. And as you can see, the patient is already in ICU care. You can see all the leads to monitor the patient, all the wires, okay? You can see that very clearly here. And then also, let me point out, this patient is also intubated. Let me point out the line of the EG tube. Can you see this one? This line here. So this is a patient that has been intubated for a while. Okay. Going now to lung abscesses, this can be because of aspiration, and one of the other causes are septic embolization. So bacteria that has traveled, neoplasia, any what you call this, cancer may cause lung abscesses, and it can come from neighboring structures like your esophagus, spine, pleura, and diaphragm. So any pneumonia which is severe and destructive and untreated can also cause lung abscesses. So this is a photo of that. Now let's go to chronic pneumonias. Chronic pneumonias usually not persistent of community or nosocomial bacterial infections, but it can be histologically. It's, sabihin natin, it's often synonymous with four classic systemic fungal, granulomatous, pulmonary infections such as your TB, histomycosis, blastomycosis, coccidiomycosis. Okay, so let me breathe first. Okay, so if you see pulmonary granulomatosis, granulomas, you think of a chronic process that can take years. So ito ay matagal. Matagal ang process nito. Okay. So looking at, these are photos of the microbes that I mentioned, the TB, histoplasmosis, blastomycosis, coccidomycosis. Okay, you have your histoplasmosis here. So histoplasmosis can be gotten from spores in bird or bat droppings. It mimics tuberculosis, and it is caused by Histoplasma capsulatum. It often causes pulmonary granulomas, and it's often large and calcified. Tiny organisms live in the macrophages. So in the United States, it's seen in Ohio, Mississippi, and not just the lungs, but many other organs can be affected. So this is a photo of that, Histoplasma capsulatum. So this shows you what it looks like on the CT scan. This is what it looks like. You see those, see that? Okay. Blastomycosis can be gotten from spores in the soil. It mimics tuberculosis like all granulomatous lung diseases. So it can cause blastomyces dermatitis. Pulmonary granulomas are often large and calcified. The large distinct spherules are larger than coccygeal, and it can occur worldwide, and there are many organs that can be affected, especially the skin. So this is a sample of what you might see on an X-ray. So let me point out here what you can see. Okay, it is large, distinct spherules, larger than the coccygeal. So here you can actually see the spherules. Okay. So coccygiomycosis are spores in the soil, and it also mimics TB. It can cause coccidiosis immitis. The pulmonary granulomas are often large and calcified, and it has smaller spherules than the blasto one. Okay, so it has tiny organisms that live in the macrophages, and many organs can be affected. And this is for a picture of a granuloma. So now let's go to compromised hosts. Let's discuss Pneumocystis carinii and cytomegalovirus and fungi. So this is a PCP. Okay. So this is a photo of, take note of the X-ray, how it looks and what you see microscopically. And as you can see, there's a lot of infiltrates going on here. So you can see that there's infiltrates on both lung fields. There's no, the costophrenic angle here is intact, so there's no effusion. Okay, so let's go back to this one. So this is your Pneumocystis carinii. And if you look at this one, okay, the right slide on the bottom, we're going to go into a close-up here. It has a woolly appearance. And then when you stain it with methenamine silver, this is the stain for Pneumocystis carinii, and you can actually see this on a close-up. So that's a woolly appearance. So that's your Pneumocystis carinii. Okay, let me point out here your Pneumocystis carinii. Okay, Pneumocystis carinii is very commonly seen in patients that have been affected by HIV. This is a common pneumonia that you would find in HIV. That's why I'm saying it's common in compromised hosts, people with immune compromise. Okay. And in lung transplantation patients, any end-stage lung disease in which the patient can tolerate long-term immunosuppression and often just one lung, it's enough. Donors are very scarce. It's very hard to get donors for lung transplant. So who are the people that may need lung transplantation? If you notice, these people are suffering from long-term or chronic illness, chronic lung disease like emphysema, pulmonary fibrosis, cystic fibrosis, and those suffering with pulmonary hypertension. And these can be debilitating. And they need lung transplantation, but it's very difficult to get a donor. So lung transplantations, infections The patients who have lung transplantations, they are often using immunosuppressives to prevent organ rejection. So they may develop bacterial infection, viral infection, fungal infection. Okay, the viral infection, they may develop CMV, or they will develop PCP. They may have acute rejection pneumonias, usually weeks to months after transplantation. And chronic rejection, half of all patients may develop this in 3 to 5 years and develop bronchiolitis obliterans, or COP, chronic rejection. So this is a sample of what you would find. That. Okay. Going now to lung tumors, there are benign, malignant, epithelial, mesenchymal lung tumors, but 90% are carcinomas. It means it's very deadly. This is the biggest killer in the United States. Its prevalence is not high as prostate cancer or breast cancer, but the mortality is higher, and only 15% will survive in 5 years. So one of the main causes here is tobacco. Tobacco has a polycyclic aromatic hydrocarbon such as benzopyrene, anthracines, radioactive isotopes. Radiation, asbestos, and radon can also cause lung tumors or cancer. Before, years ago, asbestos was being used as fire retardant, and it was being used as material for roofing. And then they found out that it was carcinogenic, can cause cancer. Okay, and then before, it wasn't in the 50s, it wasn't that clear that there was a relationship between cancer and cigarette smoking and tobacco use. And it was after they looked at the records that they discovered that these patients had a history of tobacco or cigarette smoking. And usually they have been chain smoking or smoking for years, or heavy use of cigarettes or tobacco. So what's the pathogenesis here? You have your normal mucosa. Okay, you have your normal bronchial mucosa. But what happens is there is metaplasia that happens. For example, you smoke, and of course, because of the damage that the irritants cause on the cells, in order for the cells to be able to cope with the irritation, it will undergo metaplasia. Once this becomes irreversible, it becomes dysplasia already. And then it will develop carcinoma in situ, whether what type of cancer this may be, squamous or adenocarcinoma. And then it can become invasive. It will infiltrate. So once it becomes infiltrative, then definitely survival becomes lower. It's decreased. And mortality will increase. So there are two types of cancer, lung cancer. Non-small cell carcinoma and small cell carcinoma. For the non-small cell carcinoma, this is further subdivided. Squamous cell carcinoma, adenocarcinoma, and large cell carcinoma. So this is the big list, what we call the big list. Squamous cell carcinoma, small cell carcinoma, combined small cell carcinoma, adenocarcinoma, large cell carcinoma. So this is listing down the different carcinomas. Then we're looking at other tumors here. Okay, we're still looking at tumors and cancer. So this is cancer that has actually infiltrated. Okay. So again, we're looking at cancers. Okay, TNM sa lung. TNM on your lung. T is tumor, N is nodes, M is metastasis. And this is how we stage cancer. So with T, it means we're referring to how big the tumor has gotten. And of course, I'm flashing whether it is T1, T2, T3, or T4. The N is the nodes. NO means there are no demonstrative lymph nodes. When you get to N1, it means ipsilateral hilar or peribronchial nodal involvement, means that there is nodes on the side of the lesion. N2 means ipsilateral, means it has crossed over to the submediastinal or subcarinal lymph nodes, and N3 means it has completely crossed over to the other lung. MO means there's no metastasis, means the tumor is still within the lungs. But once you have M1, then it means that the tumor has spread to other organs. And once there is metastasis, then mortality again goes up. So of course, you want that the tumor would be less than 3 centimeters, T1. You would want that there is no demonstrative metastasis or any regional lymph nodes. You want it NO, and you don't want any distant metastasis. So this is what we use in order to stage lung cancer, how bad it is already. So what are the local effects of lung cancer? So I'm pointing this out. I'm showing you the clinical features and what is the pathologic basis of the effect of this lung cancer. So I'm just going to show this to you. Very commonly, we see pleural effusion. Let me point this out. This is very common, actually. Pleural effusion, because the tumor has spread into the pleura and it becomes repetitive. Lipid pneumonia may be due to tumor obstruction or accumulation of cellular lipids. Rib destruction may happen due to chest wall invasion. SVC syndrome or superior vena cava syndrome. This is because of the superior vena cava compression by the tumor. And then you may have pneumonia, abscesses, tumor obstruction of the airway. So systemic effects of lung cancer, you may have paraneoplastic syndromes, which may be 5% of the time. ADH, patients will develop hyponatremia. ACTH, they'll develop Cushing syndrome. Parathyroid hormone, they'll have high levels of calcium. Calcitonin will be, if it be affected, then they will have low calcium, gonadotropins, serotonin, and bradykinin. So these are paraneoplastic syndromes. So metastatic tumors, the lung is the most common site for all metastatic tumors, regardless of the site of origin. So if you're having a liver cancer as the primary cause, renal cancer, or other cancers in other organs of the body. Breast cancer, very common, no, because of the proximity of the breast to the lung. The lung is the most common site for all the metastatic tumors. And it is the site of first choice for metastatic sarcomas for purely anatomic reasons. So for pleura, diseases of the pleura, you may have pleuritis, that means itis means inflammation. There's pleurisy, pneumothorax. So these are some of the diseases of the pleura. Effusions, so you may have hydrothorax, chemothorax, chylothorax. So these are, now we're in the diseases of the pleura, and then mesotheliomas. So pleuritis is usually caused, inflammation of the pleura caused by bacteria, viruses. It can be caused by infarcts, lung abscesses, and empyema. It can be caused by tuberculosis, collagen diseases like systemic lupus erythematosus, and then uremia can even cause pleuritis. Metastasis, cancer can also cause pleuritis. Okay, now going to pneumothorax. This can be spontaneous, traumatic, or therapeutic. Spontaneous, like it will just happen. Traumatic may be due to an injury, maybe due to an accident, whether it be, for example, a vehicular accident, gunshot wound. Okay, it can be open or closed. Having a closed pneumothorax is very difficult because you can develop tension pneumothorax. Tension pneumothorax happens because of a valvular effect. And you actually need to release tension in order for the patient to be to breathe and expand their lungs. Blebs or bullae rupture may cause pneumothorax, and I think I mentioned this earlier when I was discussing emphysema. Ruptures, because the blebs are very thin, very, very thin, and it's very, very easy to rupture. Perforating injuries and even post-needle biopsy can cause pneumothorax. Now, discussing effusions, we have different effusions. So this can be fluid that will accumulate between the lung and the chest wall, the pleura, in the pleuratic area. So it can be transudates, exudates, blood, which will cause hemothorax, or lymph, chylothorax. So of course, you have to know how to differentiate transudates and exudates. If you look at your past lessons, we were giving different discussions on differentiating transudates and exudates. Okay, I'll just go back to the transudates. Remember that the transudates are usually light-colored, straw-colored, no? They have less WBC, less protein. They're non-bloody usually. Whereas exudates may have a color like yellow, green, It could be pus-like. It will have increased WBC, increased proteins, increased LDH, if you remember that lesson. So I'm just putting that out there to remind you of how to differentiate transudates and exudates. So mesotheliomas can be benign versus malignant. Differentiation does not matter, but a self-limited localized nodule can be regarded as benign, and a spreading tumor can be regarded as malignant. So visceral or parietal pleura, and then the pericardium and then the peritoneum, they may develop mesotheliomas. Most are regarded as asbestos caused or asbestos related. And I was mentioning earlier that asbestos is considered carcinogenic. So this is a sample of a mesothelioma. Okay. And then with an H&E stain, this is a sample of that. Okay. So that ends our lecture for the lungs. We will be having some case reports and case assignments on the lungs. And then I will be posting some additional videos which may be of use to you in your review. And I will be posting a short video on what you would normally see in an autopsy in a COVID-19 patient. So we will have some supplementary videos that you can watch after this lecture. And then, of course, you will have case studies which will help you also in looking at and studying these lung diseases. So remember, these case studies are also equivalent to examinations. So thank you very much for joining me this today. And we finished on time. So are there any questions?
Wala naman po, Doc.
Wala naman po, Doc.
Wala naman. Okay. Okay. So kung wala naman, okay, I will be posting your case studies on your LMS. And of course, you already have the handouts for this topic for the lungs. You were previously given the handouts already. Okay, so see you soon, everybody. I'll see you all next week. And then please answer your case studies. Your quiz, instead of giving it now all the heart, I may be combining it with heart and lung exam. A long exam before giving your final exam. Okay? Okay, bye-bye everybody.
Thank you po, Doc.
Thank you po.
Thank you po, Doc.
Thank you po, Doc.